with that, speaking of, it was almost like we planted this exactly this way. So this notion of sort of freeing up more money in the system for different kinds of care. One of the things that many states have been thinking about is what is our existing infrastructure and resources spent on primary care. And many states have looked for a way to measure that. And Katie is going to talk to us about one project that did that in multiple states. And I am going to once again go off video so you can focus in on Katie. Katie, thank you so much for joining us.
Great, thank you for having us. So I just want to check that you're able to see the slide and
Yep,
it takes up your whole screen. Yeah,
we sure
okay,
can.
great, thank you. Yeah, so thank you all for having us today to speak on the primary care reporting. So we worked with NESCSO and we provided an all-payer report on primary care spending for the 6 New England states. My name is Katie McGraves-Lloyd, and I'm a senior health data analyst at OnPoint. I'm talking to you about this project because I was the lead analyst on this project. But we also have others from NESCSO and OnPoint as on the call as well, if we get to the question and answer section. So OnPoint, for those of you who don't know, we're an independent nonprofit health data organization based in Portland. We have years of experience in the development of all payer claims databases and multi-payer claims databases, as well as analytic tools and services. NESCSO is the New England States Consortium Systems Organization, and NESCSO helps state agencies improve the effectiveness of publicly funded health and human services by investing in state agencies. So now, here, our next slide. I'm actually just gonna minimize my Zoom for a second. So, see, I'm just trying to move the bar there. There we go. Okay, so this study, we used a lot of collaboration between the states and also other organizations. So the study was supported by NESCSO and the Milbank Memorial Foundation. And the approach we took is we used a distributed model. And so what that means is we worked with the states to supply specifications, and then the state analysts actually coded their own analysis and ran the reporting, and then they sent us the reporting for QA and overall reporting. And so that means that no unit record data left the states. We got all the summary reporting, and I think it made the process quicker. So the purpose of the report was to use a standardized approach to report a % of all payer primary care spending in each state, and then to evaluate if that investment held with the importance of value of primary care in each state. So just some background, there's no national standard on measurement of primary care expenditures, and no two studies have used the same methods. So we ran this study with cooperation from 6 New England states using their APCD data. We included all payers, so commercial, Medicaid, Medicare, which included 7.2 million lives. It is the first multi-state report using standard definitions of primary care providers and services. We did include OBGYN providers and services as an add-on. Some providers were not included, like naturopaths and behavioral health providers. And all 6 states were able to report claims payments from their APCDs. We also collected information on non-claims payments, and about half of the states were able to report that information. So here are the definitions we used. The first one is more narrow, and so that's a limit on specialty and procedure. So that is a primary care provider doing a primary care service, like family medicine doing a preventive visit. The second definition is more broad, and this would be primary care providers doing any service. So family medicine doing preventive care or a colonoscopy. The other definitions are add-ons. So this is OBGYN providers doing OBGYN services. And the last one is primary care providers doing OBGYN services. So this might be a family medicine doc offering contraceptive care. So as part of the distributed model, we worked on specifications that were approved by NESCSO we got feedback from the states through iterations. And so specs might say like how to pull the claims data, like limit to claims paid as primary, how to calculate allowed amount. We also sent report formats as we weren't exchanging unit record data. And so here you can see some examples of the report formats. We didn't actually report any information by individual payer. So I mean like Aetna, but we asked for that information to help us with our QA process. So for example, if we found that one insurer had a really high PMPM or a really low PMPM, we would ask the state about that and get more information there. So some strengths, all 6 states had existing APCDs and access to other data sources. The use of the distributed model worked well. So states developed their own code, which they could then keep, for future iterations. But also, we really used their local knowledge of the data. In some cases, that was really helpful. So for example, for Medicaid, for special Medicaid services. So special Medicaid services are non-medical services that Medicaid provides, like transportation. And in our specs, we define those, and we offered some guidelines for how to define that, but Medicaid is so state specific that of course the state analysts are going to know how to define that the best, whether it's using, however they would code that, like a category of service or a procedure code. So that was really a great advantage of the study. We did get specifications and formats returned to us from all 6 states, so we had 100% participation. And NESCSO, a single entity, oversaw the final specifications and methods. And we did do a lot of quality control, and thanks to the states there. So, we had a lot of questions. That example I gave earlier, if a payer had a really high PMPM or a really low PMPM. So I'm just going to walk through a couple of quick results from the claims information. So just to get you oriented to this slide, so there's 2 sections, and the dark blue section is the percent definition 1. So this is the more narrow definition. This is primary care providers offering primary care services. And then the second section, the lighter blue, it's the more broad definition. So it's primary care providers offering any service. So obviously you would expect that the percent of primary care spending is larger for the broader definition than the narrow definition. The data labels, that is the overall average across all the states. And then that yellow bar, that is the range. So, the low point is the minimum state value, and the high point is the maximum state value. So a couple observations here. One is that overall, the results are consistent with other studies, even if the methods weren't exactly the same. So for example, commercial shows 6.1%. A prior Milbank study was showing commercial numbers of 4.8%. Similarly, a RAND study on Medicare showed 2.2%, and right here we're showing 3.4%. Another observation is that Medicare fee-for-service appears to have the lowest percent primary care. It's not that Medicare individuals aren't getting primary care, it's just a function of the calculation. It's because there are a lot of other high-cost services in the denominator that pulls that percentage down. And my next slide, I focus on a different metric, and Medicare doesn't look like the lowest on primary care. So I'll go to that slide now. So here we looked at the primary care PMPM. So that's per member per month spending. The way we calculated this is we took the total dollars for a specific definition and divided by the member months. And so here, just picking out that Medicare example again, you can see they're $31 here and $50. So I think that this metric is nice to show in conjunction with the percent primary care, just for additional context. So we also included information on non-claims payments. We designed a template to collect those, and then the states took those and either went directly to the payers to get that information, or they may have had that information in-house and sort of collated what they knew. So I'll just go through some of the definitions of non-claims payments. So we took information on capitated or salaried payments, risk-based reconciliation, patient-centered medical homes, and primary care homes. Also provider incentives, whether they're retrospective or prospective, health information technology, structural changes, and workforce payments. So we structure the template in a way that we are asking for total non-claim spending and then primary care non-claim spending, with the goal that ultimately we could recalculate the percent primary care using both claims and non-claims. But a lot of the states didn't have this information. About half of them were able to provide the non-claims results. And we actually submitted an abstract to NAHDO to talk more about the non-claims results. So I won't talk about them today, but they're in our report online. So in conclusion, the distributed model worked really well. All states could use the single standardized methodology, but also tailor when they needed to. All states successfully implemented the measures across all payer types. We have a study with 7.2 million commercial, Medicaid, and Medicare lives. We did include non-claims information for about half the states. The all-payer combined percent primary care payments were 5.5% using that more narrow definition and 8.2% using the more broad definition. We think that this report provides a good baseline for future studies upon which we could expand. And I have the link here and I'll put it in the chat after. So that's all I had to share. Not sure if there's any questions or, yeah, thank you.
Katie, so there are questions, which is great. And I actually put that in the chat while you were going. So the link that was in the last slide is in the chat now as well.
Thank you.
If anybody wants to pop on over. So a couple of questions. Alan, do you want to ask your own question? If you do, you can unmute.
Okay. I was just trying to, I saw there were a list of primary care specialties, but didn't notice things like federally qualified health centers or local health departments or rural health centers, and may also do primary care. Just wondering where that included in the analysis or not.
Yes, we include facility claims, FQHCs and RHCs in the analysis.
Okay, thank you. I couldn't tell from the specialties that were identified.
Sure, yeah.
I do think that if there were sort of services that a local health department would provide that are sort of grant funded through HRSA grants or other things, those would not be included, right? These are really going to be things that are in the claims. So vaccine clinics and those sorts of things that could be handled in primary care that are handled in some of these health departments if they're not brokered through the claim system. There's probably some care happening there too that we're not going to get in that, right?
True, yeah.
All right. Julia, do you want to ask your question about ACP land?
Yes, are you able to hear me?
We sure are.
Fabulous. Okay, so hi, I am from Civic in Colorado, and we have done a similar but different data collection for APMs for the last couple of years, so I really appreciate this presentation. I feel like I've learned a lot. I had a chance to read this actually like a month ago or so, and I feel like I learned so much. So I really appreciate you presenting this, but my question to you is why you guys decided not to use the HCP land categorization for the payment arrangement types. I noticed that you guys kind of went a different route with how you categorize the non-claims payments, and I was just wondering if there was a reason that you didn't follow the HCP land categorization.
Sure. So we looked at those designations, but we also talked to other states who had collected non-claims information. And so we used what other states had done as a primary template, and that didn't necessarily align with the HCP land definitions. Richard, I know you worked a lot on that as well. I didn't know if you wanted to add something else.
I'm looking for Richard.
Yeah, I'm trying to.
There we go. We can hear
Yeah.
you now.
No, I think your answer is correct. I mean, we kind of looked at some of the other models on the non-claims payments, and we tried to amalgamate as best we could the information from other states, and we've got a lot more work to do on the non-claims payments. And actually, we're having a meeting this afternoon at 4 o'clock Eastern time to talk more about the non-claims payments. So there'll be more to come on that, I think. And I did want to just add that the primary purpose of this with the 6 states was to try to get the states to actually agree on a provider taxonomy and the service codes that we were using, so that when we do try to do comparisons, that will be, I think, more relevant when we're comparing these percentages. And we're hopeful that other states will take a look at that, and hopefully we'll find what we've done useful as they think about doing these calculations. So thanks, Katie, for all your work on this.
Great. Thank you. And I apologize. Is it Judah? Asked a question. I may be botching the name. This person may not even know that I'm reflecting on their question, but there was a
Don't worry about my funny name. It's fine.
How do you pronounce it?
Utah.
I'm sorry. Okay, well that would
It's
be why
okay.
I had
There's
no idea I was asking about
no
you.
way for
Yes.
you to know that.
Yeah, so please ask your question.
So I was wondering whether the primary care definitions you used in the reports are publicly available, so that I can try to reproduce your report for the entity I work for.
I'm not sure that we put the exact procedure codes or specialty definitions in the report. I think it's.
We did. So
okay,
all the taxonomies and the procedure codes are all in the appendix in the report. And
Great, thank you so much.
They're publicly available.
Great, thanks.
All right, thank you. Any other questions for Katie or anyone else who worked on the NESCSO primary care report? Beth, please jump in.
Yes, hi. So here in Minnesota, I'm doing the same kind of analysis, but when I break down visits from actual payments, you find that commercial payers use the least amount of primary care relative to other government payers, but they often pay more than twice as much. And when you look at expenditures relative to overall expenditures, that tends to get masked. So I'm wondering whether you would consider just breaking out visits separately from payments and then looking at both individually.
Yeah, thanks, Beth. I think that's a good point. Yeah, we could definitely consider that in the future.
Great, thanks. Okay, any other questions, comments before we move on?
This is Julia. Can I ask one more quick question?
Of course you can.
So I noticed in one of the slides with the by line of business comparison for the primary care spending percentage, I noticed that Medicaid was pretty high. I think it was the highest out of everybody. I seem to remember an 8% as compared to, I think it was Medicare fee-for-service 3.4% when you were pointing that out, Katie. And I'm just wondering what is the denominator for, is it just total medical spend, or is it, for us, at least in Colorado, we have to be very specific with our Medicaid agency in terms of what they include in the denominator and what they don't include, because their the benefits that Medicaid provides is often a lot more generous than maybe a commercial payer. So sometimes, well, for us, the denominator ends up being a lot bigger and the primary care spend looks much smaller in comparison. So there's always some context building that we have to provide. So I'm just curious about the denominator for, especially for Medicaid, and what kind of instruction you provided to your submitters.
Sure. So it's medical expenditures, but we also removed special Medicaid services. So all of those non-medical supplemental services, you know, like transportation, which can be, you know, a sizable component of Medicaid spending.
Yeah, I would just, this is Richard, I would just add that what's in the denominator is almost as important as what's in the numerator, because it does impact obviously it impacts the calculation. And the other thing I think we noted, when you look at the PMPM as opposed to the percentage of care, it kind of gets reversed. There's, you know, Medicaid, well, I'll let Katie actually address that one. But on the PMPM, there's a flip of from Medicaid and commercial to Medicare. So just wanted to mention that also. Katie, did you want to speak to that one? Or?
Oh, sure. I mean, I think you covered it. So then when you flip it and you go to the PMPM, Medicaid is the lowest at $25, right? And then it goes commercial and Medicare.
So we've got a bit of a benefit, maybe design, and a bit of a reimbursement level.
Right, when you're thinking about a PM, you know, what you're going to pay a practice for PMPM, the characteristics of their practice can make a big difference.
For sure. Okay, thank you both, Katie and for